Dentistry Education Forum 2021. На сцену
We invite on stage
приглашается
Bagrat Smbatyan. Dear doctors, greetings to all of you. Thank you to everybody for staying so late, for waiting. I understand that most of you want to sleep, but please be patient, and I thank you for your patience. The topic I want to present to you is different from clinical lectures. I want to tell you about the research side of the clinical work. All this research was started, the topic of my lecture is hypergrowth of the soft tissues. This is a phenomenon when we make the soft tissue graft and then after some time we see the increase of volume. The phenomenon that we witness sometimes, we think it's accidentally, but there is no accident. It's always some kind of objective law, some patterns. I started this research with my friend who unfortunately passed away. He deceased. I started it with my close friend, with my partner in crime. We decided together how we will do this research, how we would perform it. We started together, but I finished it without him. But I want to dedicate this lecture to his memory. When we started to learn the topic about the hypergrowth of the soft tissues, we started to analyze literature. In literature, it's called creeping attachment. There is a term from periodontal surgery, when we remove the tension from vestibulum and soft tissue starts to increase in volume. It's not from the graft, but in the foreign literature, it's called by this term, creeping attachment. And in all these sources, it is written that biologic and physiologic mechanisms are not known yet. So, physiological process is unknown. There are not many articles, but there is one article from 2018, which is professionally performed in Barcelona, in Periodontology Department of Barcelona University. They compared the grafts taken from tuberosity and from the palate, and they compared between each other the level of increasing, because clinicists often think that a graft from tuberosity is growing, but not from the palate. So they made very professional comparing. They analyzed between each other stereolithographic models. This is the best scenario of evaluation of the size. And their conclusion was that there is no statistically significant difference between the graft from palate and tuberosity. This is quite surprising because in the clinic we notice sometimes the increase of volume of the graft taken from the tuberosity, but their work was quite extensive, and their conclusion that there is no difference, it's validated. But one thing is, they took as a volume unit, so this tissue that is in the tuberosity, this is the tissue that is laid under the basal layer of epithelium. You see this beige color tissue. So that's what they were evaluating. They didn't take fatty layer, considering as a volume. So what is hypervolume? So every graft increase in its size, but hypervolume is the increase of volume when it goes beyond the contour. It's minimum twice the enlargement of the initial size of the graft. So on this picture, in the position of central incisor, we placed an implant. Implant is always narrower than the root in its diameter. So this buccal side is reinforced by soft tissues. So given reinforcement, but what you see is a hypervolume. Also, as an example, it's also a hypergrowth in the area of the second molar. I don't think you can see it often. So increase of volume in the area of the second molar. Usually we can see this picture on lower canines and upper incisors where you can witness it sometimes, but I doubt you have seen it in this area. So this is a hypergrowth, the increase of the soft tissues. It's not the bone. These are soft tissues rigidly, securely fixed on the bone. So, why should we know about that? I have to tell you that there is tissue augmentation, there is result, there is efficacy. But, for example, this kind of situation, when a patient lost her teeth during the car accident, a big tissue deficiency, a lot of hardships about the temporary prosthetics. We have to do in one step to place the implants, to make temporary prosthetic and increase the tissue volume and to keep this increase of volume. So from one action, from the gingiva with a narrow bone, with a soft tissue deficiency, in one step to increase the volume, to place the implant, make soft tissue augmentation, and have vital, reliable, dense gingiva. What I could not show you on these pictures is a density. I'm talking about the structures that, according to its density, you won't be able to discern it from the bone. When we create something dense, it's functional and it could work. The question is, how could we get a hypergrowth? For growing, we need some kind of irritant, the trigger. What could be this trigger? So it was a long way in our research of understanding that. With Karen, we always discussed the vector of blood vessels positions. We wanted to take the graft the way that the blood vessels net would be more fully inside the graft, as we thought from previous experiments that were made on animals, that the graft, initially, its blood vessel net will make anastomosis with the blood net of the wound. So its blood vessels start to work, and after that, we'll see the growth, the ingrowth of the blood vessels. And we thought that if the blood vessels net would fully work, that will get the growth, but it didn't give us any results. We took the graft with a fragment of the periodontal tissues from adjacent tooth, so we had many attempts, but we didn't have any results. At some point, I started to understand that in the world, a lot of people are thinking about that. These are people that have very good skills. They know how to do soft tissue augmentations. They know how to work with soft tissues, and they want to ride this whirlwind. So they are very experienced, but nobody deciphered it. So that led me to the thought that this answer is so elementary that nobody could see it in a close position. And then two factors coincided. I understood that this factor, epithelium, the only one possible trigger could be the epithelium. For you it sounds strange, but please be patient. I will explain it to you. So this kind of clinical situation, one of the factors that led me to this third is the discussion of the clinical case with my friend Ruslan Khatit. He's one of the most observant surgeons. In one clinical case, he managed to get the deformation of the marginal gingiva where the epithelium was present. That led me to the third. And at the same time, we had this clinical case with this hypergrowth. Here, on future surgeries, I removed this area of the hypergrowth, so I removed it as a layer, as a strip. So I removed one layer. From the lower side, it has epithelium. So the epithelium was present, and then inside layer. So I leveled it by creating this kind of layer that I extracted. What we've got from the histological analysis is inside it there is epithelium. That side is the area of the entering, and this is what was inside. So epithelium was inside this graft. Before that, it's a rare occasion, hypergrowth, we have to look for it. On this graft, we managed to get this result. So that was inside the graft. This is basal layer with papillus. There is no keratinized layer, but it was inside. And that led me to the idea that I understood that this trigger factor is epithelium. Then, to understand this situation, we know that epithelium preservation would lead to the cyst formation. We know that epithelium grows quite fast. When we put a graft with epithelium, right now purple color is epithelium left on the graft. The epithelium starts to grow very quickly on its edges. It will close and form the cyst. I knew that, and to check this idea, we decided to make two experiments. First experiment. In the first experiment, we had two mini pigs. We placed the graft in the chin area, so grafts with epithelium. They were fixed on periosteum, this split thickness flap. From one side, epithelium was outside. Another area, epithelium was facing inside. Just to exclude, you see, epithelium is going outside, externally. This is epithelium oriented internally. Two animals, four sides, all four sides with epithelium. Then the situation, you see, the wound healed. You see, the wound healing in the mouth is very important because in animals, in animal models, as Sergei said, everything could just go to breakdown. So the healing was quite good here, quite successful. This is 10 months after. We palpated the increase on volume, but when you open this area, we see the increase of the bone volume. So if you take notice, you see some small bumps. So this green color, this is increase of the bone volume. Here, I would support the idea of the previous speaker about the nuances he was talking about, that the bone could grow. We performed a long-term period of research about the periosteum graftings. I will leave this topic just for you to understand. So when we were making soft tissue augmentations and get the bone growth, when we work on animals, there is special feature. I remember in 2014 when we made the graft with periosteum, we managed to have additional growth of 2 centimeters of the bone during 6 months. First, we see this formation. We thought it's some kind of neoplastic growth, but the result was that it's a bone with thick periosteum. So we started to graft periosteum many times, and we managed to get bone graft, and when we made periosteum grafting, even we managed to do it with rectangles, but in clinic it was zero result. This kind of technique of the periosteum grafting. In the experiment, we managed to have everything, but we failed in the clinic. And we managed to understand it after some time, when once I decided to check the age of the animals. We work with 2-year-old animals. 2 years old mini pig, its biological age is like a 7-year-old kid. So periosteum has the dominating induction potential. So we grafted periosteum that was active, and that's the result we get. So please forget about it. Maybe our research would add on to your research, but your lecture was fantastic. So this is result we received. So we've got the bone growth, but the most important, we didn't get any cysts. So we were doing it for checking this, and there were no cysts. To take soft tissues for the analysis, it's quite chaotic situation. What fragment to take, how to analyze it was quite complicated. We didn't do that. So it's first experiment, 2 animals. The second experiment, 4 animals, 8 sites, 8 testing sites. We performed different sites, maxillar, posterior region, not to have influence from the muscle. You see, we took these fragments from the pellet of the animal. From one side, we fully depithelialized it, and another side, we kept the epithelium. We grafted it, and when we analyzed the results in 2 and 3 weeks, we just needed to analyze what is going on with epithelium, with the basal layer of the epithelium when we grafted on short term. So we made the sample of fragments the way. We took the fragments on the 3rd week. It was cut in half. I wanted visually to analyze this situation, to see visually the result. If you take notice on this fragment, on this edge, you see, there is partly absence of epithelium, so it's inside the sample, it's not the edge. So I cut it in 2 pieces just to see what is inside. And we analyzed the picture. So 2 weeks control side, and you see on control side we couldn't discern the borders of the graft. We can just assume that these are borders. 2 weeks test side. Did you see it before? This is 1.4 gigabytes picture made with 3D microscopy. So you can make enlargement to the image of one cell. Take notice, please, the gray color apex lateral sides, they are purple color, they are remnants of epithelium layer. This is basal layer of the epithelium. On the contralateral side there, you see giant multinuclear cells that consumes epidermis that is still in keratolysis. If you take notice, the receiving bed is directed towards basal layer. Not basal layer is going towards, the whole activity is going to its direction. On basal layer, there are a lot of cells with missing nucleus. It tells us that this area is in a degradation stage. The apex of this triangle of the gray color, this is, it calls vacuolar degeneration. So many cells are with already absent nucleus, and some cells are in the stage of degradation, degeneration. So the second week already showed it that epithelium is in generation. But the graft, it's lamina propria and submucosal layer has very nice nutrition, very nice blood vessels. It's all has very nice nutrition. But the epithelium is dying. Third week, let's see, we couldn't discern the graft area from the surrounding area. So the third week of analysis.
Вот это образцы трехнедельные образцы. То есть там, где была область контроля, ситуация абсолютно чистая.
So these are specimens and on the third week. On the control side, the situation is completely clean. Unfortunately, I couldn't skip the video the way I recorded it. So this 1.4 gigabytes image, there are no softwares that would support this image. There are special softwares for visualization where you can see this image. So I made the recording through this software. Take notice, on this sample, there are areas that there is absence of epithelium. We don't see even this degeneration layer. These purple areas on the edge, they have minimal size. Even the crevice is smaller. The crevice is smaller.
Здесь ни о какой жизнеспособности эпителия речи не идет, то есть все погибает.
You can take notice the area where the epithelium is tearing down. We couldn't tell about the living potential of this epithelium. I thought that epithelium would regenerate quite quickly and will go to the edges of the wound. But you see, it goes underneath the wound. There is no tendency for growth, even these remnants of the epithelium. Take notice, in the apex, this is the thickest epithelium in the area of apex, in this apex of this triangular. Look, lamina propria, it's a wedge into this epithelium. Let's go forward. So 2-week sample, 3-week samples. Take notice about this detail. The base of the 2-week sample is linear. They were taken as equal-sided triangles because I was cutting the periosteum from the samples, so it will be pure investigation without periosteum. This puffiness of this 3-week sample, this puffiness in this area, there are lines on the upper part. These are areas of growth. These are growth areas. So this graft, it's quite bulky, it's quite big. The situation is quite complicated. The epithelium covers 60% of the access to this graft, but this is already the growth of the graft. It increases in its size. Clinical side. I want to point out that clinical side I encountered with the difficulties of making pictures. For me, it was hard to make the pictures and to try to reveal the three-dimensional nature of the object. I'm an average photographer. I couldn't do it in that beautiful quality as my friend Amar Gazaev. So it was very hard to show the three-dimensional nature. Almost all the patients, 86 patients for 3 years, I was encountering, I was witnessing it, but to get the picture that would reveal it, that would describe it, sometimes I failed in doing that. Initial situation, quite an easy case. I say there is not enough bone, the ridge is not very wide. We graft from the tissue from the tuberosity. We took it from the tuberosity. Thickness of the graft 2 millimeters. The most important is you could not let approximation of epithelium to the edge of the wound. Then you'll have just a groove. The sulcus wouldn't be able to remove. It will be only for bed. The epithelium would survive. It would stick out from the wound. It would be on edges. It has to be covered by the flap, by the soft tissues. And this soft tissue, the flap has to be in contact with the bone. This is condition 2 months after. Initial situation and 2 months after. Another situation, another case. Well, I couldn't show you the three-dimensional nature, but you can define it on the line of the upper teeth. You see the graft thickness 1 millimeter is from the palate with a fatty layer. These are internal layers with low vitality potential. So it's graft from the palate, it's thin, thickness 1 millimeter, and we grafted in this area 1 year after. So we can define this volume if we try to compare it with the position of upper teeth. You can see the relationship of the upper incisal edge with the lower edge. What we can see is the gingiva is going beyond this incisal edge of the upper teeth. And that is from the graft with thickness 1 millimeter. Another clinical case. This slightly deformed soft tissue ridge. The main growth, it happens on the long-term period, around 6-8 months, before 1 year. What I've showed you 2 months results, it's a short-term result. The rest results would show you with the long-term results. So quite a puffy graft, not very long, but in one area is quite thick, 3 millimeters. And this area would be placed in the most concave zone. 2 months after, compare with the initial situation, and you see situation 2 months after and 2.5 years after, and you see the lateral picture. This is a hypergrowth.
2,5 года боковая фотография. Вот это гиперрост.
Another clinical case. In these clinicals, we treated this patient in the beginning of our way, when we just using cocktail. I took the rectangular graft without the epithelializing. I didn't even touch epithelium. I think it's we use this effect too much. This trigger has to be used gently. If you use it on random, that's the result you can get. This result is completely dense structure. So the graft was placed on the bone. And if you palpate it, this tissue feels like a bone. When I was palpating it, I was thinking that there is a bone growth. You palpate it like an exostosis. We made a CBCT, so it's not the bone, it's soft tissue. Of course, we don't need it at all. It's useless here. Maybe later you can perform a surgery and take it as a donor site for the soft tissue augmentation. So this is just hypergrowth when we put the graft with epithelium. Clinical situation. Patient after the car accident, we see narrow ridge that could let us to place implants with a diameter of 3.5 millimeters. We placed 2 implants, we made soft tissue augmentations and do immediate temporization. The problem was of the soft tissue augmentations because of the temporary prosthetics due to many reasons. So this the emergence profile, 2 years after, you see the external emergence profile, and you see that the soft tissues goes beyond this emergence profile of 4 millimeters. So if you look at an apical part, it goes beyond the gingival margin. In a picture in front, you see this kind of tuberosity, but these tuberosity areas you can see only when you stretch the lip. Aesthetically, it's if you take this picture, maybe it's not we have to strive for, but I'm not talking about the clinical situations. I'm talking about a hypergrowth. I'm showing you clinical examples where I prove that hypergrowth will be due to the epithelium. I'm not talking about the result itself, but in here it was the best decision. But in front picture, look at the lateral, in profile picture, there are no sticking out tuberosities because of the contrast effect of the color of the mucosa. This effect on the front pictures. Of course, if you look it in the smile, it's all quite satisfactory clinical situation. position. There is absence of lateral incisor of the canine and two premolars. Here, in the area of the lateral incisor, the width of the bone is minimum. So we take the soft tissues from the tuberosity and divide it into two lobes. And I made experiments with the position of epithelium in the lateral incisor position. I placed it. Epithelium was going internally, and in the canine area, the epithelium was going externally. We suture the graft. I don't think it's new information for you. That's the way we fix grafts in this area. The view of the wound after the grafting, 2 months and 4 months after the surgery. The situation 4 months after, you see the profile. Situation 1 year after, you see the hypergrowth in the position of the lateral incisor. This is hypergrowth. Another clinical case, this is complex clinical case. We see narrow crest of the soft tissues and very narrow bone ridge. So there is no wide bone. When visually sometimes we see very narrow soft tissues, sometimes underneath them we can see average width of the bone. That could help us to make the surgery in one step. Here it's another situation. The bone is quite narrow. Caries looks awful on the picture, but I didn't want to remove it before the surgery, because during the surgery we closed the recession, we placed two implants, and we corrected the soft tissue volume. I didn't want to deal with the filling with the composite material. We removed these caries during the surgery. Here I was using different technical solution. As you can see, the ridge is quite narrow. We make the root surface preparation. We extract the second molar. See, the implant placed with compression technique, with the densification kit. So there is no problem with the initial insertion due to the densification. But the bone is very narrow. We make the preparation of the root surface. The main thing here is the graft itself. Take notice, I almost cut all the soft tissues from tuberosity, and I divided this graft on the 3-section cobble. Looks like an accordion. So the 3-section cobble, one part I depithelized. So I wanted to use one part for the recession coverage, and this hyper volume was useless. Other 2 sections had to be laid in the area of implant and in the position of the absent tooth, because the ridge is very narrow in the premolars region because they're absent, and because of the and the second molar, the ridge is quite wide. We don't need to compensate it with this kind of graft. During the surgery, I noticed it later on the video, there was slight displacement. This epithelium edge, if you take notice, it is going in the middle of the tooth. The condition 1 year after. So 1 year after the surgery. Take notice, please, on the width of the gingiva underneath the crowns. There are no voids, there is no artificial gingiva. The fit is quite good. Look at this tuberosity. This is the part that displaced forward. Why? You can see it here, because it is going around the whole area, because in the anterior region, this is mismatch that you will be able to project here. If you palpate, so in the posterior region where there was not enough volume, right now the volume is quite natural. So of the natural width of the ridge. And here in the anterior region you see this disbalance, this mismatch that you were able to see on the pictures. The last clinical case from this series, initial situation, here these implants had to be extracted. One is inflamed, another one is not stable according to the period test. We measure the width, you see on the right side, the width is less than on the left side. Take notice, right implant has inflammation of the surrounding tissues, and the gingiva is narrower, and also it has a zone of inflammation. The surgery itself. See, the left implant was extracted with the healing abutment, I mean the right implant, and left implant was extracted with minimal effort. It's not even the special removal kit, it's just the torque wrench that was adapted. The whole situation, so there was a situation when the graft was placed on the bone, you fix it on the bone. In this situation, we make dense volume, immobile. In this situation, because the situation initially was quite complicated, we made the graft, so we took the graft very thin, 1 millimeter. Half of this graft was deepithelialized, another half was not fully deepithelialized. You can see the thickness of the graft, more or less 1 millimeter. So this graft was inserted in this area. In a way, it was risky, because usually to take this big volume is quite risky, but this is very revealing situation. On the right side, initially, there was less tissue than on the left side, so the tuberosity is not from the graft is not from the tuberosity, it's the strip from the pellet, strip with a thickness of 1 millimeter. The epithelialized part was on the left side, not the epithelialized part was on the right side. With 3 sutures, we fixed the graft. The situation 2 months after. You can compare right and left side between each other. The condition 1 year after. This is a picture with a focus on the area of 2-2, and here we make focus on 1-2-1-1. You see the difference in volume. But please point out the retractor for the pictures we use the same. You see the marginal tissue is slightly stretched during the picture taken because we use split thickness flap, and graft was placed on an area of the split thickness, so it was part of the tissue that could be mobile. When graft is laying on the split thickness area, it is go in its natural habitat, and here it was the right decision. You see, this situation visually demonstrates the effectiveness of the deepithelialized part and part with the epithelium. The last part of my presentation about cysts. I showed you, if you trust me, you can understand that cysts are not forming from the epithelium. Objectively, it's like that. I showed you the experiment with its analysis, I showed you the clinical part, but where are the cysts come from? This question exists. It's quite a rare phenomenon. We look in the literature, there are not so many publications, and all of them are case reports. So the article written about one clinical situation is quite a rare condition. When I started to use microscope, I understood how often I left epithelium during the epithelialization. Even under the microscope, it's quite a hard work. It's a first point. And the thickness of epithelium in basal layer sometimes could be reaching 2 millimeters, and we couldn't even discuss the full-scale deepithelialization because we have to remove 2 millimeters. There is a technique called Brunner technique. We'll have to remove 2 millimeters. 2 millimeters. We work with a graft usually having a thickness of 1 millimeter, so it's impossible. I'm talking about the thing is we leave epithelium very often in the graft, but we don't see a lot of cysts. I can tell you about the 5 cases of cysts I encountered. Maybe 5 times I just didn't notice it or forgot about it, but it's very rare condition. It has to be the reason. All the articles about this topic, these are case reports, and talking about that epithelium was left in the graft. But I found one article, this is a translation from English, that said that just the presence of the epithelium tissue is not enough to get a cyst. There has to be additional factors. When a cyst present after the soft tissue graftings, maybe it's due to the trauma because of the surgery. It's quite cool because it's just an article. These are just the thirds of the author. These are reference, not references to the researchers. These are the reference to the other case reports with other thirds. But we had one situation. Once I was sending to the histologist this histology analysis. We're doing it, in routine, not without any cause, and we were analyzing this hypergrowth. And the histologist told me that I made the soft tissue grafting of the graft with epithelium. The thing is that I sent him the sample of the graft taken from the pellet. So it is what it turned out that the graft itself that was with epithelium. These are the fragments of the basal layer of the epithelium. So this is basal epithelium. This is upper and lower fragment. So this is the covering tissue that was inside. This is a natural process. It could not be in norm. No, there couldn't be skin inside the muscle. So this is impossible. And analysis from the other side, from this patient, showed that there is nothing like that on the other side. So, in the way we encountered it, this is what kind of structure we noticed. And that's prompted me to the thing that maybe it's a normal anatomy of the palate with these areas of the epithelium inside. So this kind of, unknown fact. We performed the analysis. I managed to get 2 cadaver pellets. So the mucosa taken from the pellet of the cadaver, and I want to give credit to Armbach and David for getting this. They're working on cadavers, and then they went to work on cadavers. They took 2 samples of the pellet mucosa, and they gave it to me. So this pellet, and we cut the lateral areas. So about some areas that we think are fully understood, for example, anatomy of the vessels of the palate. As I knew that palatal artery exits through palatal foramen and it goes in the middle, between the medial and lateral side of the palate, and create anastomosis with incisal artery. Look, cut at the border of the first and second molar, 2 arteries with 2 mm diameters and 2 arteries with 1 mm diameter. We always think that it's thoroughly researched, but maybe it is not researched at all. When I first saw it, I thought, well, it's good I have seen it right now, not before I started to work with soft tissues. And this is analysis. You see, the second sample, I call this sample, this fragment, what we take from animals, we call it biomodel, and this to be delicate. This is the second sample. The whole palate was dappled with this epithelium. You see, we call it ectopy of the epithelium, invading of the epithelium inside. This mesh, that's how these fragments are formed. Gradually, this basal layer, its leaks are descending inside. These lines, so it descends inside. So in these samples, we understood how it happens. This sample is coincident with a clinical sample that we've got in a clinic when we first encountered it. So how these ectopic sites are formed. The third sample, from one side it exists, from another side, so this is there it was. From the other side, it's completely clean, no epithelium inside at all. If it's normal anatomy, then it couldn't be situations where it's absent. So it means it's not normal anatomy. It's kind of a process. Look, the first sample, on the right side, there is, on the left side, there is no. On the second sample, there is a presence on the right and left side. You see, in the third sample, there is a presence on the left and absence on the right. It seems chaotic. How you can explain it? Beautiful boy. I wanted to ask this question to see who would give me the correct answer. Suran David. Well, perfect. He even didn't give me a possibility to make that intrigue. We have to rewind it backwards. The thing is that the patient that was in the clinic for 8 years, he was masticating on the right side. When he came to us, when the right tooth was destroyed, the second and third sample. So, the second sample used denture. The third sample had teeth on the left side. So, the patient has to adapt to the load. The cheek and the tongue that are present in the mastication, they can balance their load. So, we will not make too much pressure. The teeth are worn out. This is a result of the loading. But palatal mucosa could not escape, but we don't see blisters on the palate like on the hand and feet, but it has to be some kind of process of adaptation. This is biological mechanism of densification of the mucosa. When epithelium would bring these islands inside, and as it breaks, it would reinforce the mucosa. If this area would be punctured during the suture, it would lead to some kind of inflammation. And as you see, this aseptic inflammation, it has to be some kind of discharge, and that's when the cyst could form. And you can couldn't predict it. For example, if we have the choice where to take it from, we could have to take it from the area that was not overloaded, but it's quite rarely. Usually we take the soft tissue where it's more thickness, where it's more accessible. When we make sutures, when we use the needle, we don't know whether there is islands present or not. We have to send this tissue for the morphology, for the histology analysis. But it could present in 2-3% in our practice, but it's unavoidable. We could not know it beforehand. In the end, I want to give credits. I want to thank to members of our team. I want to thank my assistants, Natasha and Nadezhda. These are my assistants. They worked for 10 years with me. They come with me to vivarium, and there was never time when they excused themselves from that duty. I want to thank our histologist, Alexei, as he comes, he has himself arbitrator. I want to thank the members of the team of Medino Marchiani. He is doing literature research, translation of the articles. I want to thank our members, my student, to Georgi. For many years he was traveling with us. Right now he's working. He couldn't travel a lot, but when he could, he always helps us. Thank you very much for your attention.